Good afternoon, everyone. Thank you for joining us at the New England Sleep Medicine Seminar. As you know, in the chat, there'll be a code for CME credits that you can text to the number provided. Let me see how many people we have. I think we can go ahead and get started. So it is my pleasure to introduce Dr. Kiran Maski, an associate professor in the Department of Neurology at Harvard Medical School and a internationally renowned expert in hypersomnia disorders. In addition to her numerous publications, including very important work to reduce diagnostic delays in pediatric narcolepsy, she has been invited regionally, nationally, and internationally for talks, lectures, chairing symposia. She served on multiple task forces to develop clinical guidelines for treatment of hypersomnia disorders, as well as writing practice parameters to conduct MSLTs in children. And she was awarded the 2024 Research Pioneer Award from Wake Up Narcolepsy. I can't think of anyone more deserving. And she also was my mentor when I was a fellow in sleep medicine for my pediatric portion of my fellowship. I learned so much from her, and I'm very excited to hear her speak today. So without further ado.
Thank you, Sokol, and what an honor it is to speak to all of you. I'm just going to close this. So my topic today is about focus on the nighttime sleep characteristics, about central nervous system hypersomnia disorders, and perhaps what it can teach us about improving diagnostic conundrums we currently face. So these are my disclosures. The central nervous system disorders of hypersomnolence really is quite a tangle, and I think that's the first issue we have clinically. We have conditions such as narcolepsy type 1, which might separate themselves from this tangle, given the unique symptoms of severe daytime sleepiness and cataplexy. But the rest of the conditions really do have a lot of overlapping features. So narcolepsy type 2, idiopathic hypersomnia, subjectively sleepy patients who say they're very sleepy, but then have normal MSLT criteria. And then an entity called long sleeper, which is where patients sleep more than 10 hours and generally need that in order to feel good. But in our society, unlikely to get that because of work or school schedules. So they're always operating at a slight sleep deprivation state. So as I mentioned, a lot of these symptoms, especially when it comes to narcolepsy type 1, type 2, and idiopathic hypersomnia overlap, but they have different ranges of severity. So just to go through that, daytime sleepiness, fatigue, sleep inertia, brain fog, cataplexy, sleep paralysis, hypnagogic hallucinations, seeing something you're not sure is real as you're falling asleep or waking up, refreshing nature of naps, depression, anxiety, and total sleep time. But of all of these, I think there are some symptoms that do seem unique to idiopathic hypersomnia. Sleep inertia, for one, tends to be much more common in that group, and this is a symptom of difficulty fully feeling awake at least 30 minutes to an hour after waking up from bedtime sleep, nighttime sleep. The refreshing nature of naps oftentimes is very unclear or clearly not beneficial, I should say. In idiopathic hypersomnia, where refreshing nature is oftentimes emblematic of narcolepsy type 1 and type 2. And then the total sleep time can really vary in idiopathic hypersomnia from normal to extremely long. And in a study of patients with self-reported symptoms of idiopathic hypersomnia, 80% said that they typically get 9 to 11 hours of sleep. Cataplexy, again, is unique to narcolepsy type 1, and I'll have some focus on this, but the bulk of our talk today will be on idiopathic hypersomnia. In terms of the objective findings, even though some of the features I mentioned, things like sleep inertia and total sleep time, are the differentiating features of idiopathic hypersomnia from these other conditions, we focus mostly on what we can test with a multiple sleep latency test. And this would be the most common testing we used for the diagnosis of idiopathic hypersomnia. Essentially, what the concern is that patients who have normal or long sleep durations have variable amounts of this criterion of 8 minutes or less on the mean sleep latency test. So depending on what study you're looking at, within the idiopathic hypersomnia group on an MSLT, 34 to 100% of patients who had normal sleep durations would fall asleep quickly on the mean sleep latency test, meeting the 8-minute threshold, but much fewer with long sleep duration, and this was defined by 10 hours or more, would meet that criterion, 29 to 56%. Of course, we define these disorders by the MSLT, so it's sort of a circular issue. But I think we can all agree that we do see the 8 minutes and 2 sleep onset REM periods maybe more reliably in narcolepsy type 1 and type 2 than we do in the idiopathic hypersomnia group. And it is possible for idiopathic hypersomnia patients to have 2 sleep onset REM periods during their MSLT and not have a narcolepsy. And the data has been basically based off the revisions in the International Classification of Sleep Disorder, 3 text revisions, which now allows the diagnosis of IH, even if there were 2 sleep onset REM periods, if the practitioner feels like it's a better fit with the IH condition rather than narcolepsy. I think most experts are of the opinion that idiopathic hypersomnia really is 2 different subtypes based on the sleep duration at night. So there's the subtype that has normal sleep duration, and those patients might overlap with the narcolepsy type 2 patients, where they might fall asleep quickly during the MSLT, and they could even have 2 or more, or 1 sleep onset REM period, but not 2. But phenotypically, they're very sleepy. Sometimes they might have refreshing naps. That small subgroup, people want to lump in together with the narcolepsy type 2 or collapse the conditions and maybe even make the condition called narcolepsy spectrum disorder. Versus the patients who have the long sleep duration, which is actually the majority of patients with idiopathic hypersomnia based on sleep billing time, who have long sleep duration and might have normal MSLT studies. So separating those 2 out based on the long sleep duration clinically is something recognizable. But at this time in the International Sleep Disorders text, we don't have subtypes. That was collapsed after the second iteration of the ICSHD. I think we all know that the sleep duration certainly can be emblematic of idiopathic hypersomnia, but currently we don't have ways of really employing testing in a clinical setting in a reliable fashion. So you might be familiar with the ICSD now allows testing based on actigraphy or an extended 24-hour polysomnogram for the diagnosis of IH. But practically speaking, actigraphy is costly. It's not reimbursed by most centers. And so essentially it's an out-of-pocket loss if the device is lost. Also, patients might have unrestricted sleep times in order to get accurate sleep duration, so 660 minutes or more of sleep per week. And that might not be when they are in school or have, work schedule or whatnot. So practicality is an issue with actigraphy. And then extended polysomnograms, sometimes we might get lucky and I can convince our sleep technologists to arrange their shifts to do consecutive testing for this long duration of time. And here, when you're able to get an extended polysomnogram, we're trying to look for if there's 660 minutes of sleep. But this can be very resource intensive and costly because currently we're not allowed to bill for 24-hour polysomnograms. There's no such billing mechanism for that. So given the challenges of actigraphy and obtaining 24-hour polysomnograms, we rely on the MSLT most commonly. And here's a patient who meets the criteria of the 8 minutes or less. You can see they have a 1 sleep onset REM period, but not 2. But sometimes the diagnosis of narcolepsy type 2 and idiopathic hypersomnia can be problematic simply because if a patient has a long sleep duration, excuse me, but a lab doesn't allow for extended polysomnogram, if that patient has an MSLT, they might end up having what appears to be narcolepsy type 2 because the long sleep duration is captured during the daytime testing, and they could have sleep onset REM periods and meet the MSLT criteria. So I think this in itself has led to some problems with disentangling idiopathic hypersomnia from narcolepsy type 2. This was a study done by Honda and group, where they studied 35 patients with idiopathic hypersomnia, narcolepsy type 2, as well as patients with essentially sleepiness of unspecified condition or diagnosis, and looked at the sensitivity, specificity, and accuracy of a 24-hour polysomnogram compared to PSG MSLT. And on this, basically the MSLT had incredibly poor sensitivity, 12%, if the criteria was 8 minutes or less for distinguishing idiopathic hypersomnia from the other conditions. But it did have better specificity of 80%, and the accuracy was only 34%. Versus when they used this 24-hour polysomnogram, it seemed to capture the patient's symptoms more readily. So the sensitivity went up to 92%, but specificity went down a little bit by 60%. So the conundrum we really have is that we might be missing many patients with idiopathic hypersomnia based on our reliance on the MSLT, but we don't have the capability of doing studies that capture the long sleep duration. And I'm sure you're all familiar with this. As a result of relying on the MSLT, there's huge problems with misclassification and reliability of the diagnoses of narcolepsy type 2 and idiopathic hypersomnia. So we know that the classification consistency for idiopathic hypersomnia based on MSLT testing is only 25% and less than 50% for narcolepsy type 2, meaning you could do the test more than once and get different results of the diagnosis. So this, I think, conundrum sort of has led me to start looking into, like, are there other sleep features or other biomarkers of these conditions that can help distinguish them from one another for diagnostic purposes? And certainly this was motivated by narcolepsy type 1, which phenotypically has a very unique sleep presentation. First of all, the nocturnal sleep onset REM period has been well described in narcolepsy type 1. And essentially, this is a REM period that's occurring within 15 minutes from sleep onset on the polysomnogram. And that biomarker has a sensitivity of 50%, but its specificity is close to 95%. The presence of this and the robust nature of its diagnostic features is sufficient now for making the diagnosis of narcolepsy type 1 on the new ICSD-3 text revisions, as well as the DSM-5. But we know that there are other features of narcolepsy type 1 that make it unique. There's a number of sleep transitions that occur during the night. So this is a patient in B here with narcolepsy type 1, and you can see that they have a very fragmented sleep where they're going from sleep to wake, which is shown in blue here very often, but then they also have transitions into N1 sleep or drowsy sleep. So we had done studies, which I won't go into too in much detail here, showing that this index of sleep to wake or sleep to N1 divided by total sleep time was also a helpful diagnostic biomarker that separated narcolepsy type 1 from other central nervous system disorders. There's other things that have been published in the literature, transitions from N1 to REM and low transitions from REM to N2, a high overall presence of N1, the presence of REM without atonia, and the presence of indeterminate sleep stages, meaning it has features of REM or it has some features of N2 mixed together. All of these have been well described in narcolepsy type 1, and again, have been used for separating out the condition and potentially could be used for diagnostic purposes down the road based on a PSG alone without the MSLT. And this was highlighted by Emmanuel Mignot's machine learning paper, which was recently was published in 2018, where essentially this was a neural network analysis of 3,000 sleep recordings of narcolepsy type 1 patients compared to other conditions. And essentially features that were identified from the machine learning algorithm, many of which are recognizable, such as a early onset REM period, frequent transitions into N1 and wake, and specifically this transition of N1 to REM, are all noted based on this neural network analysis, and its output yielded a specificity of 96% and sensitivity of 91%. So essentially, the compilation of these biomarkers is helpful for identifying narcolepsy type 1, again, without the need for an MSLT. So this might be something where these sleep biomarkers are essentially very helpful for improving diagnostic, both accuracy as well as the delays that we currently have. So looking at if there's any unique sleep features of narcolepsy type 2, people have looked at this over the years, and it doesn't seem like there are anything that's particularly unique, at least compared to controls. No differences in total sleep time and the number of wakings, for instance, or sleep stage transitions. Some studies have indicated that there's a shorter REM sleep onset latency for narcolepsy type 2, and in pediatric studies, they might have an increased amount of REM sleep. Compared to idiopathic hypersomnia, really no differences have been reported across a number of literature searches, and but one study showed that perhaps narcolepsy had an increased amount of REM sleep compared to idiopathic hypersomnia. Compared to narcolepsy type 2, it seems that the narcolepsy 2 patients had fewer numbers of sleep onset REM periods, overall less N1 or wake after sleep onset, and essentially had increased sleep efficiency, less sleep transition, so more normal sleep compared to narcolepsy type 1. And as we know, the HLA positivity, sometimes this is done clinically in our work that had been previously published. Patients who had narcolepsy type 2 who were HLA positive for the DQB0602 allele actually had more phenotypic sleep like the narcolepsy type 1 groups. So it made us wonder if that presentation is there early and they haven't developed cataplexy, maybe it's a biomarker in itself of having future cataplexy development. In terms of idiopathic hypersomnia and defining the sleep phenotype, David Plant had done a systemic review and meta-analysis of polysomnograms for idiopathic hypersomnia compared to healthy controls. The caveat being that the idiopathic hypersomnia patients were more variably defined and included both long sleep time as well as MSLT, as well as clinical judgment. Based on a comparison of the studies, however, the idiopathic hypersomnia patients tended to have longer sleep, more REM sleep, shorter sleep onset latencies, decreased amount of slow wave sleep, and lower sleep efficiency, although that was found in females only compared to controls. In identifying sort of these patients with long sleep time and normal sleep time within the idiopathic hypersomnia group, some people have looked at if there's differences in the sleep features beyond total sleep time. Interestingly, the patients with long sleep time actually had higher sleep efficiency than those with normal sleep duration. And the timing of when the last slow wave sleep episode was later in those patients with long sleep time, but there was no difference in other features. So I think it makes idiopathic hypersomnia patients with long sleep time somewhat unique. Normally, when we have longer bouts of sleep opportunities, sleep actually gets more fragmented. But here's a group that truly needs this, who truly seems to use all that time for sleep based on their sleep efficiency. And the later onset of slow wave sleep might suggest that there might be a reason for the sleep inertia that they clinically experience. So there has been some movement to use these sleep phenotypes in diagnosing patients. And you might be familiar with this study, which was done by the Dovier group in 2021, where they came up with a protocol of a 32-hour sleep study where the cutoff was essentially 19 hours of sleep differentiated patients with idiopathic hypersomnia with good accuracy and reliability. Just to walk you through their protocol of how they did this, they would screen patients with a PSG MSLT, and then they would have a second assessment, giving them a polysomnogram and then a modified MSLT, and then they kept them in for 32 hours in the lab, in bed rest state. So meaning they couldn't get out of bed, they would be allowed for transitions or ADL kind of stuff, but it was sort of in monitored bed rest essentially to identify their capacity for sleep. Based on the cutoff of 19 hours, they did see that there were some differences in patients similar to the last study I showed you, where the sleep efficiency was higher in those that slept 19 hours. Again, I think although it's not that different from 90.8 in the less than 19-hour group, I think it's really notable that these are patients who have such high sleep efficiency, high sleep needs, that they're filling all that time with good sleep. It's not necessarily fragmented or deficient in any way. I think the other finding was that in this group, the patients who had the 19 hours of sleep or longer ended up having slightly more N3 sleep compared to those with 19 hours or less needs. But I think that's a little bit hard to interpret. So more recently, we started to look at more novel sleep analyses beyond just total sleep time, sleep efficiency, or standard things that come out on the output. And so various groups have looked at different mechanisms of machine learning in order to identify novel combinations of sleep features that might help separate out narcolepsy type 2, idiopathic hypersomnia, and type 1 patients. This was a study done by Gould and colleagues where it's called algorithmic hierarchical clustering, where essentially you're going from bottom up in terms of building phenotypes. So you look at where certain clusters are overlapping, and if those clusters are overlapping, that might be a condition entity in itself, and then you add another variable and you see where that clusters and so on. So you're sort of building up to a diagnosis based on the features you're extracting. And in this study, the features they were extracting were from polysomnogram and MSLT. So they used variables like PSG total sleep time. Some of the sleep variables we're familiar with: sleep efficiency, sleep onset latency, the HI, PLMS. But they were also able to incorporate sleep symptoms based on surveys of snoring, nightmares, sleepwalking, and habitual sleep durations. So based on that, they came up with some clusters of patient descriptors. So cluster 5 for one was of interest because it presented with sleep drunkenness, subjective difficulty waking, so probably that's sleep inertia, memory complaints, fatigue, and a larger weekend to weekday sleep differences. And I think clinically we recognize that group as idiopathic hypersomnia. Patients oftentimes don't have the capability of sleeping the desired amount of time they want during the weekday, so they catch up on weekends. They oftentimes complain of brain fog, fatigue, and that, again, sleep inertia and sleep drunkenness. However, there were no objective sleep features that clustered with this particular grouping. And that might be because these are polysomnogram MSLT done in standard fashion. So oftentimes the nighttime sleep duration is constrained, so you can do the MSLT in the morning. Cluster 6 was this HLA positive DQB1 patients who had low hypocretin levels. Again, that's sounds like narcolepsy type 1. But beyond this, there was really no disentanglement of features of narcolepsy type 2 and idiopathic hypersomnia based on this machine learning study. And there were no objective distinguishing sleep features from non-cataplexy patients. So we started to look at other ways of analyzing sleep. And one of the ways we came across that was employed in Tom Scammell's work, looking at narcolepsy orexin deficient mice models and looking at sleep stability in those animal models, we basically tried to apply to CNS disorders of hypersomnia. So this was a study that we had done with 46 narcolepsy type 1 patients, 12 narcolepsy type 2, 18 idiopathic hypersomnia, and 48 subjectively sleepy patients. And most of these patients were young, 6 to 18 years of age. And we extracted sleep features from their polysomnogram primarily. And we looked essentially at what's called the stability of each state. So we used survival curves, which I'll show you in a second. We oftentimes use for death or some adverse event, but here we were looking at how long does a state remain stable before it transitions to something else, and then we were able to compare those curves with Cox proportional hazard models. So just to give you an example, so this is sort of wake bouts. How long is a wake bout lasting before it transitions to something else? So on the x-axis, we have the duration of the bout, and on the y-axis, we have the percent survival. So we know as soon as someone wakes up, essentially everybody has brief wakings during the night. But what we saw is that as those bouts get longer, that's where the curves between groups start to separate, such that patients with narcolepsy type 1 really can't sustain longer bouts of wakefulness during the night. They're transitioning back to sleep very quickly. And so even though their sleep is incredibly fragmented, their wake bouts are relatively short. Compared to patients, compared to idiopathic hypersomnia and narcolepsy 2 patients who, essentially they seem to have normal bout ranges compared to the control groups. So similarly, we applied the analysis to REM bouts, and you can see that in narcolepsy type 1, there's a really steep decline in the stability of REM sleep in narcolepsy type 1. So again, once they're transitioning into REM sleep, they're quickly transitioning back out of it, suggesting that these are really rapid transitions. Non-REM 1 sleep, interestingly, distinguished narcolepsy type 2 from other groups, such that when patients with narcolepsy type 2 transitioned to N1, they tended to stay there for longer periods of time, proportional to other groups. And so essentially, maybe this, even though I told you from the literature, narcolepsy type 2 sleep seems very similar to control type of sleep, but patients report oftentimes really feeling unsatisfied with their sleep. It might be because they just sort of have longer bouts of non-REM 1 and don't feel as refreshed after that. Interestingly, we also found that narcolepsy type 1 patients had really poorly sustained non-REM 2 bouts, and essentially, again, transitioning quickly out of that. We just completed a study that's in review looking at if this poor stability of N2 also contributed to memory consolidation problems, and found that it in fact does to some degree, especially if spindles are cut shorter with the transitions. But interestingly, in idiopathic hypersomnia, which is shown in purple here, when patients with idiopathic hypersomnia transitioned into N2 sleep, they tended to kind of stay there. And so that might be perhaps why they sleep more deeply. They have less fragmented sleep and might be difficult to wake up in the morning. We also found that in a subgroup of idiopathic hypersomnia, meaning the older patients, meaning 16 and over, that patients oftentimes had poorly stable N3 sleep with idiopathic hypersomnia. So once they were transitioning into N3, they were quickly transitioning out, and maybe that contributes to their poor, refreshing sleep quality overall. So just to summarize that, if we sort of group some of the features I mentioned, narcolepsy type 1, at least based on the sleep phenotype, tends to have highly transitional sleep. They have very brief wakings during the night, but frequent wake bouts. They have unstable N2 and unstable REM sleep. And so this might be attributed to orexin loss, which we know is fundamental for the stability of states, mostly for wake, but when it's lost, perhaps the stability of sleep is also lost. Versus NT2 seems to have more stable sleep overall. However, they did have more N1 stability, and maybe this is what happens with mild loss of orexin, although that needs to be studied. And then the idiopathic hypersomnia patients have more stable N2 sleep and less stable N3 sleep. And perhaps that's a reflection of overly stable non-REM 2 sleep. Could that be the yield of GABA receptor potentiation or some type of prolonged physiologic night with lack of suppression of melatonin? We don't know, but essentially it's this type of analysis gives us perhaps some methods to study those hypotheses. Moving on, I think, how we're starting to see some of this work develop is still in the domain of machine learning. And this was a study that employed some of the sleep stability measures I just mentioned to see if that perhaps could tease out patients. And it was a relatively small group, but novel analysis to see if that could be separated. And what this group found was that essentially only narcolepsy type 1 with the sleep stability features I showed you could be distinguished. Those features were slightly different than what I mentioned, but the increased amount of N1 sleep, at least later in the night, the stability of N3 sleep was higher in narcolepsy type 1, and the short REM latency, which we're all familiar, were very distinguishing features of narcolepsy type 1 from type 2 or idiopathic hypersomnia, as well as sleepy controls. Compared narcolepsy type 2 compared to idiopathic hypersomnia and subjectively sleepy patients, features that tended to differentiate narcolepsy type 2 were a decreased number of REM to N2 sleep, an increased amount of late N1 and decreased N3 bout duration, so shorter N3 durations. And idiopathic hypersomnia, at least patients compared to subjectively sleepy controls, had earlier amounts of longer N2 percentage and less wakefulness at the end of the night. But you can see the accuracy in terms of the diagnosis compared to the columns that they're in is relatively low, other than narcolepsy type 1. I think that this paper went on to investigate some novel metrics that were identified from hypnodensity plots as well as automated sleep features. Some of these are things that certainly did separate statistically patients, but we don't really understand the clinical significance of them. So for instance, narcolepsy type 2 versus sleepy controls was separated based on the features of transition peaks of REM to wake, the time taken before 5% of a product of different sleep stages between N1 and N2, calculated every epoch, and then weighed by the total amount of sleep. So you can see these are sort of features that might be extracted by machine learning, but certainly not recognizable to us as useful, or at least clinically useful or clinically recognized as features that we could easily identify. But maybe these are things that could be looked at in more detail. So for instance, idiopathic hypersomnia versus sleepy controls, features that were identified were REM sleep in the first 4 parts of the night increased the likelihood of idiopathic hypersomnia. And maybe that suggests that there could be some alteration in melatonin, which is very regulative of REM sleep in this population. So it sort of generates some hypotheses that might be interesting versus the maximum amount of wakefulness in the 4th parts of the night decrease the chance of idiopathic hypersomnia. And so perhaps there's something about, again, the features of homeostatic sleep pressure that are reducing the amount of wakefulness. So again, although they're not clinically recognizable, could be hypothesis generating. And my last slide here is just that sleep metrics. I think where we're moving is that we need to integrate some of these sleep metrics with real clinical features that we do know about the conditions. So this was done by Susto and colleagues, just recently published in Frontiers of Neurology, looking at what's called a dynamic simulation model. And so essentially what they're doing is they're looking at clinical variables, comorbidities, sleep measures, treatment response to stimulants, And each one of those is a clinical feature that's used as a measure or a certain variable. And then they ascribe cause and effect to the variables. So maybe, you report less sleepiness after getting a stimulant, for instance. They also determine the strengths of the relationship over a course of a certain amount of time. And then they run the models to see what clusters together in terms of all these features together. And interestingly, they got a very, I think, a good classification of idiopathic hypersomnia based on variables. I think we recognized that I started this talk with: sleep inertia, refreshing potential of naps, the quality of nocturnal sleep, and the burden that there was placed on the patient's lives. Interesting, there was low influence on whether there was a psychiatric condition or not, and medication responses. And that might speak to that we don't have great medications, such as if they were relying on wake promoting medications that actually were beneficial, that could tease this apart. So it's a long way of saying that, I think our clinical acumen, as well as some of these measures that I've described, probably need to be working together, and that nocturnal sleep features are certainly a really important part of this, and really takes us away from just relying on a single test, the multiple sleep latency test. So in conclusion, unique features of narcolepsy type 1 are known to exist, and certainly this could be built on for diagnostic testing on the polysomnogram alone, which might help us identify narcolepsy type 1 more quickly. And we need to do further work on narcolepsy type 2 and idiopathic hypersomnia to achieve similar goals. I think exciting measures such as bout analysis, as well as machine learning, might offer sort of differences in how we've currently looked at sleep. So, of course, these are not easy to do and require large numbers of patients. And this really calls for data repositories and data sharing to be the norm here. We also have the circular problem, really, of we face diagnostic challenges of classifying these patients, and then we're using those classifications to make our sleep features or identify our sleep features. So in the end, we might have to be agnostic, kind of like the last study, as to what people's classification actually is, and just see what comes up in terms of feature analysis, and then build on tests that can identify those specific features. So for instance, long sleep time, I mentioned a few times now, seems to be really critical in separating out idiopathic hypersomnia in a number of these studies, yet we don't do studies that incorporate long sleep time. So one potential move forward would be, if we have to do a PSG MSLT, maybe making sure that we're getting at least a 12-hour night or something like that, and then modifying the MSLT to be later, so that we can capture that long sleep duration and see if they still meet the MSLT criteria. So that's protocols that we're actually testing out now with other sites. And ultimately what we come up with in terms of how to accurately measure these patients and their symptomology needs to be feasible and generalizable. So I think things like a 32-hour forced bed rest protocol is admirable. I don't think it's something that we can actually do across the country. HLA testing in narcolepsy type 2 might help with identifying kind of a subtype of patients that have a phenotype more common to narcolepsy type 1 and might be predictive of cataplexy down the road. And then certainly more complex diseases probably need to be entered into these models to kind of differentiate things like hypersomnia with psychiatric conditions. But I think a big message is that in order to achieve better results, meaning diagnoses, we have to be using some form of standardized protocols, and we need to use surveys and other sort of clinical features of these patients for making accurate diagnoses. So I'll stop there. These are thanks to my mentors, Tom Scammell and Bob Stickold, and all our collaborators and research assistants and funding sources over the years, and of course, our patients. Thank you.
Thank you so much. That was fantastic. And I think very timely as well. Our first question in the chat, what is the proper definition of sleep inertia versus sleep drunkenness from Dr.
Yeah,
Matt?
it's a good question. I think sleep drunkenness is sort of, I would say they operate on a continuum, but sleep drunkenness is where there's actually like ataxic features, almost slurred speech, cognitive function problems, um, almost like what it sounds like, essentially, that differentiates from sleep inertia, which is just sort of the difficulty waking up and feeling refreshed, getting up and going.
And then Dr. McNally is asking, what definitions do you use for fatigue and brain fog that distinguish them from sleepiness?
Oh, well, I think that clinically is all I can answer. They probably are all very overlapping features, but sometimes patients can say, even if I wanted to, I couldn't fall asleep during the day, but I just feel so tired, I'm dragging. To me, that's much more clearly fatigue. And frankly, sometimes we make the mistakes ourselves of not disentangling the terminology. We do an MSLT. It's completely normal for a patient who reports like severe sleepiness. And then we kind of unpack it a little bit more and realize that they actually were just saying that they were tired all along. And so that's important. Brain fog. We've done some studies about language of how it's actually clinically described, at least in a young population. It seems to be effortful thinking, difficulty with processing information, difficulty getting words out in a timely fashion, and memory problems.
I find a lot of patients with obstructive sleep apnea describing themselves of having brain fog that improves with PAP treatment. And it's
Mhm.
some form of psychomotor delay when I've asked them to elaborate more. I think
I
I
think that's
agree with
right. Yeah,
everything you're
I
saying.
don't think it's unique to any specific condition, but it is very commonly reported in idiopathic hypersomnia.
Other questions?
Yeah.
I think a lot of the time, oh, he says, I asked the question in part because of curiosity about overtired in children. Any thoughts on why children are different?
Yeah, I think I don't know. I think maybe they have a stronger drive to be like their peers and, they push through sleepiness a lot. I think in my experience, sleepiness in children oftentimes manifests as sort of hyperactivity and inattention. And it's really, I think fatigue is something that we tend to hear more in the adolescent group. So yeah, I think they just don't complain of it as much.
And treatment-wise, do any of these variables suggest the superiority of one medication versus another one?
Yeah, that's really helpful. So I think one point I should have made is there have been a few studies that differentiated treatment response in patients with long sleep duration versus normal sleep duration in idiopathic hypersomnia. And it does seem like wake promoting medications really are only beneficial to patients with normal sleep duration and not those with longer sleep duration. So I think, I focused on diagnosis, but I think that these sleep features, there might be important information that guides therapy too.
Well, this is very timely. I think right now we're paying a lot more attention to precision medicine, different endophenotypes, the heterogeneity of different sleep disorders rather than lumping everything together. It's not a one size fits all. And I also think it's very important because we may not pay as much attention to nocturnal sleep as we should. Sometimes clinicians focus on the daytime symptoms and falling asleep during the day for these hypersomnia patients, but there's a lot to learn, as you've elucidated, from their PSG and from their nocturnal sleep habits. Does anyone else have any other questions of Dr. Maskey before and feel free to unmute and ask your questions as well, if you'd like.
Oh, I didn't check the chat. I don't know if there was anything.
Oh, those were all from the
Those
chat.
were the questions. Okay.
Yeah.
Great.
But anyone can unmute if they'd like as well.
I'll ask a question. Does a high sleep efficiency really go against narcolepsy?
Oh, yeah, thank you for that. I think the problem, if you want to say it, for narcolepsy is it is a variable presentation of disrupted nighttime sleep. So the range of people who report having poor sleep at night ranges from 30 to 90%. So I think that high sleep efficiency certainly could be, and in fact, uh, if we're just talking about the objective measures of sleep efficiency, most narcolepsy patients have high sleep efficiency, primarily because those wake bouts I showed you are very brief. They actually spend more time in sleep than, say, like an insomnia patient. So I don't think that it rules it in or rules it out for narcolepsy. But I think what I was trying to highlight is just the imagery of the fragmentation, that sort of like sleep, wake, sleep, wake, sleep, wake, and those transitions is what's more or less unique to narcolepsy type 1.
Well, there's a high S3 sleep in a older adult really push you against narcolepsy or push you toward idiopathic hypersomnia.
No, none of that has actually bore out, like a particularly N3 in particular. Certainly not for narcolepsy, and for idiopathic hypersomnia, there's, it doesn't rule it in or rule it out. There's maybe more observation that slow wave sleep or N3 sleep is reduced in idiopathic hypersomnia, but again, very small studies.
Is there any advice or insights onto the frequency of hypnagogic, hypnopompic hallucination or frequency of sleep paralysis to differentiate the conditions?
Yeah, I mean, it's certainly more commonly reported in narcolepsy type 1 compared to type 2, and type 2 compared to idiopathic hypersomnia. But yeah, I mean, I think idiopathic hypersomnia, if patients have long sleep duration and they force themselves awake, they might wake in a REM state and experience similar sleep paralysis, hypnagogic hallucinations. So I don't think we've disentangled its relationship from long sleep duration.
And also along those lines, I remember learning that if you have narcolepsy, you should really have these symptoms very frequently. So if someone is reporting these symptoms just once, a few times a year or even once a month, is that fair to say it's not necessarily related, or is there sort of a
Yeah,
threshold you would
that's
use?
actually a great question. I think like if you look at studies where they look at the reporting of hypnagogic hallucinations and sleep paralysis in new patients with narcolepsy type 1, it's only 20 to 30% report having that symptom to begin with. So I think, these episodic symptoms are really hard to put a quantification on in terms of separating them out. So meaning that some people have very clear narcolepsy with cataplexy and might have only experienced sleep paralysis once, versus someone who has, more frequent symptoms. And sometimes it's a function of disrupted sleep, meaning how often they're napping during the day and then they're getting sort of insufficient sleep at nighttime. And there's a lot of variability with that frequency.
So with that in mind, would you advise against using those symptoms to try to differentiate between type 1 and type 2 narcolepsy if the PSG MSLT, like they're on an SSRI or something else where you can't use maybe SOREMs or, well, I guess that would be more IH in narcolepsy, but if there's confusion or they're on something that could be suppressing cataplexy, could you use those symptoms to differentiate, I guess,
clinical
IH from narcolepsy, or would you advise against doing that?
I don't think so. I think
Okay.
it's not really been studied enough to know like what the cutoff is or
Okay. Because I've argued clinically if they have a lot of hypnagogic pompic hallucination, sleep paralysis, even if their MSLT matches IH, maybe it's actually narcolepsy clinically,
yeah.
but I don't know if that's
Yeah, I can understand that. I mean, I think I can't cite a particular study, but I think
sure.
clinically that does feel right.
Okay.
What do we know about the histaminic dysfunction in IH? Is there any connection between the two?
Oh, that's a good question. I don't know if it's really been studied. It has been studied in narcolepsy type 2, and histamine ends up being actually a very difficult compound it's not very stable, so it's actually very difficult to measure. But there were no differences in histamine, at least between narcolepsy type 2, when that was looked at. But to my knowledge, no one's looked at it in idiopathic hypersomnia.
Common clinical situation I think we see is someone that maybe we do a PSG to rule out sleep apnea or something else, that there's some symptoms to go for and it's negative, and you're starting to think hypersomnolence disorder. And getting back to your idea of the survival curve for wake bouts, could we come up with a cutoff that has a high negative predictive value for a hypersomnolence disorder, or particularly narcolepsy? Like if you have someone who has a bout of 2 hours of wake on your overnight study, can you definitively or with high confidence at least say it's unlikely to have a primary hypersomnolence disorder?
Yeah, I think that's sort of where we're headed with our new research and I don't think, unfortunately, it's going to be a single measure, but sort of that compilation of findings. What we're looking for is there a sleep signature essentially that is comprised of things like the wake bouts, that's comprised of the sleep duration, that's comprised of N3 amounts, that distinguishes a phenotype that seems like idiopathic hypersomnia from other groups.
Well, thank you so much, Dr. Maski. This was an incredible talk. And if anyone has any other questions, ask now or.
Yeah, no, thank you for your attention, everyone.
And I know you're on service, so I really appreciate you taking the time. So thank you again.
All right, take care, everyone.
Bye.